Hello, and today we are going to discuss about adenomatoid odontogenic tumor, commonly called AOT. This is a high-yield odontogenic tumor frequently tested in exams and often confused with the dentigerous cyst or even ameloblastoma. So, understanding AOT is important because its behavior is benign and treatment is conservative. So, before moving forward, please subscribe our channel as it gives me motivation to make more videos for my, you know, colleagues, all the dental graduates who are struggling, as the name says, last night dentistry. So I'm just helping you guys by just extracting important points from the book and helping you guys. So we are going to move forward now. Now, first, we have to consider why it matters. So, AOT is important for two main reasons. Firstly, it appears regularly in your BDS exams, even or your ADC exams, maybe part 2 or part 1 exam, especially as an MCQ or image-based question. Secondly, clinically, it mimics more aggressive lesions. If you misdiagnose it as ameloblastoma, you may overtreat the patient. So, recognition of AOT directly affects clinical decision making. So, that is the reason why this matters a lot. Now, moving towards the definition and the overview. Adenomatoid odontogenic tumor is a well circumscribed, encapsulated, benign tumor derived from odontogenic epithelium. It usually develops around the crown of an unerupted tooth, most often in young patients. So key phrase you have to remember are encapsulated plus benign, and also it is a tooth associated. Now moving forward towards the etiology. So AOT most likely originates from the reduced enamel epithelium or EE. This is supported by its location around unerupted teeth and histological features. The tumor shows duct-like epithelial structures. This is important to remember, which gives it a glandular or adenomatoid appearance. This origin is a must-remember exam point, okay? That this tumor shows duct-like epithelial structure. And exam highlight, as I have highlighted, it originates from reduced enamel epithelium. Coming to its pathophysiology or mechanism, the process starts with proliferation of odontogenic epithelial cells. These cells arrange into swells and duct-like patterns. Within these structures, PAS positive eosinophilic material is deposited, resembling basement membrane. In some cases, spherical calcification also develop inside the epithelium. So that's how it works. Now, looking at the clinical features, you have to remember always that AOT usually presents in the second decade of life, commonly around to 14 to 15 years of age. And if we're looking in which gender it is dominantly found, it would be female than male. The most common location is the anterior maxilla, especially around an impacted canine. So, exam highlight is also an impacted canine. So, patient typically present with painless swelling and a failure of tooth eruption. So, that's where we can call it an AOT, or we can have a doubt about it. So, classic ride, you have to remember young plus female plus impacted canine. Now coming to the diagnosis and key findings. Looking at the radiographically, AOT appears as a unilocular, well-defined radiolucency, often surrounding an impacted tooth. Unlike our dentigerous cyst, okay, the radiolucency extends beyond the CEJ, cemento-enamel junction, which is a classic exam clue for you guys. Some lesions show fine radiopaque flakes due to calcification, as I have told in the pathophysiology. Histologically, the tumor is now looking at the histo of this tumor. The tumor is encapsulated, composed of spindle epithelial cell and hold wall patterns, as you can see here, with characteristic duct-like structures and occasional calcification. Duct-like structures and occasional calcification is a major finding about this. So this was its radiographic appearance and histological features. Moving towards the management or treatment, so we have to understand that AOT is a non-aggressive lesion. Okay, so treatment is simple. Management involve conservative curettage, usually with removal of the associated impacted tooth. We have to remove it as well, extract it. Okay, no radical surgery is required, and recurrence is extremely rare. So it is non-aggressive behavior means it could be a conservative treatment. Now we got a clinical scenario to help you guys. Like imagine a 15-year-old female, okay, second decade of life, and she's a female with painless swelling in the interior maxilla. So this is the point you have to understand. Radiograph shows a well-defined unilocular radiolucency around an impacted canine. Okay, impacted canine shows, as you can see here, well-defined unilocular radiolucency extending beyond the cement to enamel junction with small radio-opaque flakes. Okay, small radio-opaque flake can be seen. This presentation is classic for adenomatoid odontogenic tumor. Okay, so you have to always remember this. This will help you in diagnosing an AOT. So the key takeaways from this very lecture are that AOT is a benign encapsulated odontogenic tumor. It commonly affects young females and associated with impacted anterior teeth. I will again say an impacted anterior teeth. Treatment is simple curettage and recurrence is rare. So, as I have this topic is mainly covered from your oral patho textbooks, including Neville and Maxillofacial Pathology, Shafer's textbook, and all these books. I hope you have got some concept about this topic, and I must share some quiz about this on my reel section. I hope you just find it helpful. If you find it, please just subscribe it, because I definitely need your support. If you keep subscribing it, I will make more and more videos and help you guys in every other ways. You can comment which kind of topic or what series you wanted, so I can make it very easier for you guys. I hope you have enjoyed and it is helpful. At our motto is last night industry. At the very last moment you open our videos, just start making notes and you understand the concept. Thank you very much. We will meet in next